So Seemaji, just let me know when we are live.
Sure, sir. Yes, sir, we are live.
We are live. So, good evening, everyone. My name is Dr. Girish Kumthekar, and I welcome you all to this Nephrocon webinar series. This is 34th installment of webinars, what we are conducting in last 2 years. I am with Dr. Manan Doshi, Dr. Suhas Monde, Dr. Purva Bhavikar, Dr. Saurabh Kiste, who constitute the Nephrocon team. And we are supported by Acognos. Ms. Seema Kaul looks after the operations of Nephrocon. With this, I will start with today's topic, which is POCUS, current perspective and practice. So ultrasonography done by a nephrologist and done by a critical care specialist and done by a radiologist. The tool is the same, the probe is the same, but the eyes which see the screen are different. So the perception of those ultrasound findings by a nephrologist, a critical care specialist, and a radiologist might differ. So this is the forum where we have our speaker, Dr. Arun Thomas, who's a professor of nephrology from Tiruvalla, Thiruvananthapuram, who will be taking us through the journey of POCUS in nephrology, the perspective and the practice. And we will have our esteemed panel members, Professor Vinit Behera, who is with Armed Forces Medical College, Pune, and my dear friend, Dr. Vivek Kumar, who is a professor of medicine, head of critical care medicine at Symbiosis University Hospital and Research Center, Pune. So we will be talking about use of ultrasonography, and we will be getting questions from the YouTube platform. Just some housekeeping notes. The talk is almost 30 minutes. Remaining 30 minutes, we will be coining some questions to the panelists and the speaker, and we will get answers to most of the questions. And at the end of the webinar, I am very confident that we'll get a lot of enlightenment on POCUS. So with this, I request Dr. Arun to start the talk. Thank you. Thank you.
Yeah, I will share my screen.
Yeah.
We can't hear you.
Okay, I will share once again. Am I audible now?
Yeah, you are audible.
And the screen is visible, right?
Yes, screen is visible, and now it's in PowerPoint mode also. That looks good.
Now it is good, right?
Yes, definitely.
Okay, thank you. And it's a great introduction. And I like the intro that the eyes which is looking at the screen is different. So with that background, let me start the POCUS in nephrology. This is a big area. So it is just an overview and perspectives and the practical uses I will be rushing through in this 30 minutes. Always POCUS came into the nephrology, critical care, etc. for initially for fluid status assessment. So let's start with fluid status assessment. So before POCUS, say like 2010, 2005, 2010, everyone was assessing volume status clinically in AK and CKD and all. It's very subjective. Just like you see the screen, how many logs, 4 or 3, is very subjective. I'm not saying the POCUS is very objective. It is not 100% objective, but it is much, much more objective than clinical due to various reasons. For example, if it is an edema, so a patient with sepsis, septic shock, they can have edema, but the intravascular volume will be very depleted. And edema could be because of the hypoalbuminemia. And if you go behind the edema, you will miss intravascular volume depletion. Similarly, chest crepitations, even in volume depletion, you can hear chest crepitation because of the ILD, COPD, atelectasis, and bronchiectasis. So always a POCUS has a role in critical care nephrology. I'll just start with a case. So it's a 45-year-old male, post-renal transplantation with a baseline creatinine 0.96. See, he came with fever and chills of 2 days and anuria of 1 day. BP is 80 bar 50. Blood urea is 190. Serum creatinine is 5.4. Sodium 129 and potassium 4.2. So perfectly normal graft. It is a sepsis. Now patient is anuric, severe acute kidney injury. So he came to the nephrology unit and he was started on blood cultures and a broad spectrum antibiotics and was given a 1 to 1.5 liters of fluids, and still urine is not coming. The unit decision, this going back to 2017, so the unit discussion was to start on emergency dialysis since a patient is anuric. A sled was planned, but just looking at the IVC, you can just see the IVC is 100% collapsing. So I just told, please hold the dialysis. Let's hold the dialysis. Just give more fluids. So many told me already 1 liter, 1.5 liters of fluids to an anuric patient was rushed in 1.5 hours. So it's not safe to give more fluids. It is in 2017 time. So everyone was not very aware of the POCUS and all. Just showed everyone, this is the IVC. This is 100% collapsible. Let me give fluids. I kept on checking IVC every hourly and keep on giving fluids. And the 6 hours, I could give 12 liters of fluid to a totally anuric patient. So is it practically possible without the help of a POCUS? It is not possible. And even after 12 hours, we can see the IVC size becomes reasonable. And see, 12 liters of fluids in 6 hours to an anuric patient is only possible because I could monitor the IVC collapsibility. And the patient urine started to come, blood pressure improved, and there was no requirement for the renal replacement therapy. So just about the IVC. IVC is very easy to check. You can use a curvilinear probe or a cardiac echo probe, phase array probe. You can place it in subxiphoid location and you can just see the view of the IVC atrium. And this is how
So,
you have to place. This is how you have to place the probe. The IVC is towards the right, so slightly tilt the probe towards the right and slightly tilt upwards so that atria is also coming into the view. And you will be using a B mode and you can visualize the atria and the IVC. And in the M mode is a motion mode where the one-dimensional mode is being obtained, and we can just measure the collapsibility index. So in a normally ventilated patient, normally respiring patient, it is IVC collapsibility index, and in a mechanically ventilated patient, we call it as a distensibility index because IVC collapses during inspiration and distance during expiration normally, and it is vice versa in a mechanically ventilated patient. And if it is intravascular volume depletion, the collapsibility will be very marked or pronounced, and in severe volume depletion, we'll get a fully collapsing IVC. And it is always better to check the IVC collapsibility index, which is a maximum diameter minus minimum diameter in a M mode divided by maximum, rather than just an absolute diameter at any point, because IVC diameter keep on changing between inspiration and expiration, and also it changes through where the ultrasound beam is passing. If it is beam is passing tangentially, we'll get this as lower diameter and it's called a cylinder tangential effect. But if you take the IVC collapsibility index rather than absolute diameter, that error is nullified. So you have to, and a common mistake everyone makes is in a mechanically ventilated patient, still everyone call it as a collapsibility. We should not call it, and it is always a distensibility index. And this is another view through which we can visualize the IVC, and it looks like a double barrel gun if the subxiphoid location view is not very good. And I'll come back to the same patient. I gave 12 liters of fluid in 6 hours. Initially, IVC was 100% collapsing. Now it is only 41% collapsing. So what next? So any IVC collapsibility more than 50% means it is intravascular volume depletion. If it is less than 30%, there is enough volume. Between 30 to 50, it is a gray area. You have to individualize. So after 6 hours, my next question is, can I give more fluids to this patient? More fluids. Already I gave 12 liters. So everyone around me told, hey, it's time to stop giving fluids because I already give 12 liters. And I checked the IVC, it is now 41%. I am also confused. But BP is still soft. So can I give some more fluids or stop or start an evacuation therapy by giving a diuretics or anything or start a dialysis? So we have to take a decision. So always you have to classically we auscultate our lungs for lung crepitations. But if you are well versed with the POCUS people always uses the lung ultrasound more than the chest auscultation, because the lung ultrasound is much more sensitive to pick up the lung water, extravascular lung water in the form of B lines. B lines is artifacts produced by the lung water, and the B lines can be even visualized even before we pick the lung water using stethoscope. So at this point, we have to again closely check all the zones in the lung for any B lines. If the B lines is not there, we know that the lung there is no pulmonary edema. So then again, the question is just about where all we have to look the lungs. We divide in the chest into four quadrants: upper and lower mid clavicular and upper and lower mid axillary line. So in each four quadrants, we have to keep the ultrasound probe between an intercostal space, and if there is more than B lines in one zone, that is significant. So back to this case. So here already gave 12 liters, lung is still clear. Now can I give more fluids or not? That is a question. So some may tell that I will reduce the dose of, I will reduce the fluid rate. Some may tell I will stop. Some will tell I will still continue. So we need to we have to fine tune our decision. So IVC is not absolute. The problem is if you give excess fluids, it results in venous congestion. If you for this patient the lung is clear, but I'm still keep on giving fluids. And what will happen if I keep on giving fluids? Sometimes the venous congestion sets in. So I will be very happy looking at the monitor that the blood pressure is increasing because I'm giving fluids. Lung is still clear. But if there's a venous congestion, the hepatic veins, the portal veins, and the renal veins find it very difficult to drain into the IVC, and the venous congestion results in organ damage because the blood can move into this liver and kidney, but it cannot move out. So that itself affects the perfusion in spite of the improvement in the arterial BP. So after enough fluid resuscitation, when the IVC collapsibility is now less than 50%, so we have to go into the veins inside the organ and see whether it is congested or not. So vexus, the term vexus seems to be confusing or a hi-fi for many, but it is not very hi-fi, I will say. We are just screening the Doppler waveforms in hepatic vein, portal vein, and the renal vein. And first, we always start with the hepatic vein. So this is the hepatic vein. We just press the pulse wave Doppler mode, keep the sampling gate inside the vein, and we'll get a waveform. I'll come to it. So waveform in the hepatic vein do change. It has got S and D two negative waves and V and A two positive waves, just like how we have an central venous CVP. Just like it, we have the hepatic vein venous changes also there in the Doppler. So if you just look at the screen, we can just see the three columns. The first part, it is a normal. Every waves are negative. And the last part, and the right side, we got see it is a biphasic pattern in severe hepatic venous congestion. So we are just concerned about severe venous congestion. If it is a severe venous congestion, it is a biphasic. Usually S and D are negative in the biphasic, S positive, D negative. So it is very easy to identify. Just keep the probe just like we use for the IVC measurement. And we can just see the IVC and the hepatic vein draining into the IVC. We just keep the sampling gate in the pulse wave Doppler, and here we can see two negative and a positive wave. It is not congested. And this is the other view, subcostal view. Like here, you can just see the hepatic vein like this. Here also, we can just see, you can see S and D waves are negative and A wave is positive. There is no congestion. And just looking at the biphasic pattern, we can know if the hepatic vein is congested. If for this patient, if the hepatic vein is congested, it is a definite indication to stop further fluid resuscitation, or you can even consider giving diuretics or taking out the fluids to RRT or something if the urine output is not great. And second thing is a portal vein. The portal vein flow is always a smooth flow, but this flow gets more and more pulsatile. I can just see in the figure if there is a severe portal vein congestion. So portal vein is very easy to identify. Keep the probe in a subcostal region like this. And you can see, very easily identify the portal vein. Portal vein has got a white halo around it. You can just see. something which a white halo around it is always a portal vein. Just keep the sampling gate inside the portal vein and do the sampling, and you can just get the waveform. So maximum minus minimum divided by maximum, you will get the pulsatility index. If the pulsatility index is more than 50 percentage, here 19.3 is a maximum, 7.1 is a minimum, divided by 19.3 is more than 50 percentage. That means it is severe venous congestion. So if the portal vein is not congested, it is will be a smooth flow. Pulsatile flow means portal vein is congested. If it is congested, it's time to stop further fluids and take out the fluids if it is already in excess. And next is a intrarenal vein. So intrarenal vein, just you have to renal vein also, it is a smooth flow. We cannot just sample renal vein alone. We are actually doing a renal artery Doppler. Anything above the baseline is a renal artery waveform, and anything below the baseline is a venous waveform. Arterial and the venous waveform we obtain in the same graph, because in the kidney, wherever there is an artery going in that direction, there is a vein is taking blood towards in the other direction. So you can just see how when the congestion is there, the smooth flow is disturbed, and we'll just get a discrete small pulses below the baseline. So we have to first visualize the kidney. If you're seeing the kidney, you can just see the adjust the gain and etc., and you can measure the length, kidney size and all, and you can just see the CMD. That is not the part of the vexus. Anyway, you are going to see the kidney, and you will just press the color Doppler mode. You can just see the color artery and venous color in red and blue, and we just keep the sampling gate in the pulse wave Doppler inside a renal artery, either in the hilum or any of the main renal, any of the branches, and we get a renal artery Doppler, and that is what we find above the baseline. If we have a renal arterial Doppler waveform like this, what we can also get an RI. RI is a maximum minus minimum velocity. Maximum means a peak systolic velocity minus end diastolic velocity divided by peak systolic velocity is an RI. And below the baseline, you can just see the venous film, which is a continuous flow. So there is no venous congestion. And whenever there is an acute kidney injury, RI increases. RI means it is a pressure that is exerted against the inflow of the blood to the kidney because of the renal parenchymal pressure. Whenever there is acute kidney injury or any acute graft dysfunction in post-transplant setting and everything, there's some swelling of the renal parenchyma occurs, and blood find it's very difficult to move in. So the diastolic velocity decreases and RI increases. So RI should be below 0.7 always. So along with the renal venous Doppler for the vexus, we can always check the RI also. You can just see the last part. You can just see the severe renal vein congestion. You can just discrete D waves, which is very easy to pick up. And in the arterial waveform, above the baseline, you can just see that end diastolic velocity is coming down. This is because of the venous congestion. The arterial blood is finding it difficult to move out, so RI is also increasing. So increasing RI and the non-pulsatile discrete renal venous flow means the kidney is also congested. It's time to stop more fluids, because more fluids will worsen the renal status. So everything put together, we can just see how much severe abnormality is there in the renal artery, renal vein, hepatic vein, and portal vein. You can grade using a vexus. So you can just go through it when you get time. So I'm not going into it. And back to the case. So this is the case where I gave 12 liters of fluid in 6 hours, and now IVCC is 41%. Lungs, there is no B line, and I checked the vexus. There is no significant congestion, then I will keep on giving more fluids. But if there is a congestion in the vexus, I will stop giving fluids at this point. So we don't need to do vexus for all patients. Should be done after the initial fluid resuscitation, when the IVC is reasonably full, so that we have to fine tune the further fluid management, not at the start when the IVC is grossly collapsing. And sometimes for the beginners, vexus, it may be very difficult. So some training, IVC is very easy. Vexus 1 week training is needed. And another thing you can do for this case, if you don't know, or if you is not confident with vexus, is carotid artery Doppler. Carotid artery Doppler is very same. The concept is, so during inspiration, the venous return to the heart increases, and expiration venous return decreases. So whenever there is an increase of venous return to the heart, the left ventricles and all are dilated. So the myocardium is stretched. or the length of the myocardium muscle fibers is longer after inspiration. So the force of contraction of the myocardium is directly proportional to the length of the myocardial fiber. So that is a Frank-Starling law. So after venous return, the myocardium is stretched and the force of contraction will be high, and already there is more blood in the ventricle, so the stroke volume will be very high after inspiration. After expiration, all the blood is taken during inspiration, so there is less blood coming to the ventricle. So ventricle is not stretched, there is no enough blood, stroke volume will be less. So there is a significant stroke volume variation between inspiration and expiration. So this inspiratory expiratory variation, the stroke volume becomes very pronounced if there is an intravascular volume depletion, because all the blood will come during inspiration, and after expiration there is no blood to come or drain into the heart. So it is we can check the stroke volume variation by using an echo, but it is very difficult. But we have to keep in mind that whatever blood is pumping into the aorta is pumped into the aorta, that fraction goes to the carotid. So the carotid blood flow increases after inspiration, decreases after an expiration. So, but blood flow means velocity into area. So area of the carotid artery is going to be the same. So it is a velocity that is going to change. So the carotid artery peak systolic velocity will be very high after inspiration, will be less after expiration. And this variation will be more than 14% if there is a intravascular volume depletion. So that's a whole concept of the carotid artery Doppler. It is very, very simple to do. So we'll just do a carotid artery Doppler. Maximum minus minimum velocity divided by average velocity is a variation. If it is more than 14%, it is intravascular volume depletion. We can give more fluids. So it is very simple. Just keep the vascular probe like this in the carotid, just how we put an IJV dialysis catheter, and locate the carotid artery. Now place the probe longitudinally. We'll get the carotid artery, pulsating carotid artery. It is very simple. After that, press the color flow and some steer. There is a button called angle steer knob. Steer it and then press the pulse wave Doppler mode. We'll get something like this, and we get the sampling gate should be inside the vessel, and an angle correction knob. We may keep this line parallel to the vessel, and we'll just measure. We get the carotid arterial waveform, and we measure the maximum and the nearest minimum. So maximum minus minimum divided by the average, it is the carotid artery peak systolic velocity variation. Here it is 16%. So even after I gave 12 liters of fluid, still the variation is 16%. That means still there is an intravascular volume depletion. And since the BP is soft, I can give more fluids. And a senior consultant came to me and told, hey, you already gave 12 liters of fluid. So you're again going to give fluid based on this carotid artery Doppler. How sure you are about this carotid artery Doppler? In that case, you can just club it with a dynamic maneuver, like rising straight passive leg rising. If you rise the leg, it will be like an auto bolus of 300 ml of fluid into the circulation, because the capacitance vessels in the leg contains a lot of blood. 300 ml of the blood is held in the vein in the calf and the legs. So it immediately, because of the 300 ml of the blood into the circulation, the BP increases, and also the carotid artery peak systolic velocity variation, which was 16, it will come down to 12, 10, or even less. So it is just like giving a 1 liter of crystalloid bolus. Just passive leg rising is equivalent to 1 liter of crystalloid bolus, and you can just see whether the carotid artery peak systolic velocity variation is coming down. If it is coming down, we can be very confident that you can safely give more fluids. So that is mainly about the fluid management in acute kidney injury and sepsis and stroke. And just rush about the lung and IVC ultrasound for dry weight estimation in the hemodialysis patient. We know that dry weight is very, very, very crucial for hemodialysis patient. If the dry weight is correct, most of the patients do have a very controlled BP and less cardiovascular events and all. But most of the clinically determined dry weight can be errorful, and we have got bioimpedance and all for measuring for correctly defining the dry weight. But the POCUS can be also used. So we are going to club the lung ultrasound and IVC ultrasound together. Lung ultrasound means it gives extravascular fluid volume in the lung, and the IVC assessment means intravascular volume. And after a good dialysis, if the patient is in the correct dry weight, the IVC should be 50 to 75% collapsing, and total number of B lines in the lung should be less than 4. If this criteria is not satisfied, if the B lines is very high or IVC is less than 50% collapsing, that means still excess fluid, excess volume is there in the body. The dry weight or the weight at which the patient coming out from the dialysis unit is not the dry weight. You have to take out more fluids. So if you, every time 30 minutes after a dialysis, if you just check the lung and IVC ultrasound, you can know whether the patient is in correct dry weight. If it is not in the correct dry weight, you can reduce the dry weight. And if the IVC is more than 75% collapsing, you have taken out more fluids. So don't reduce that much. And in spite of collapsing IVC, if the lung is full of B lines, it could be an ILD or it could be severe left heart failure that the lung is never going to become clear. You can just do an echo and find out. So this is a 8 zone lung ultrasound. You can just see a lot of lung B lines in it. And now, in the last 5 minutes, I will just rush through some AV fistula and preoperative vascular mapping. And this is some area where we should be using POCUS by ourselves rather than relying on the radiologist, I always feel. Because for a successful AV fistula creation, I feel this Doppler of the upper limb vessels is not very mandatory. But when the vessels are of the borderline characteristics, we may have to get the correct picture of the vessels using a Doppler. If it is a Doppler, we should be doing it very properly, because morphologically we need a diameter, vessel wall thickness, wall alteration, vessel course, and veno-occlusion lesions, and two functional parameters: assessment of the blood flow and ability of the artery to dilate. I will come to it. So in the radial artery, we measure the diameter. If the diameter is 1.5 to 2 mm, it is okay. And if it is 2 to 2.5 mm, it is good. More than 2.5 mm, it is superb. But if the diameter is less than 1.5, don't do it at all. And the radial artery peak systolic velocity should be more than 50 ml per minute. The brachial artery, we are not very concerned, because the brachial artery is always a large artery and it will be always good. It won't create a problem. All the problems will be the radial artery. If the radial artery is very too bad, even if the brachial artery is good, we don't do a fistula because of the steel problem. So we just palpate the radial artery, keep the probe like this. We have to measure it is 0.27 centimeters, is an excellent radial artery diameter. Then we can see the wall echoes, and in the calcified wall it looks like this. And in the pulse wave Doppler, so we have to do an angle steering and an angle correction. Always remember angle steering and angle correction, then only we get the correct peak systolic velocity, and it is 102. That means it is more than 50. The radial artery radiocephalic AV fistula is doable if the vein is good. Next and final thing that we have to always do, but the radiologists don't do it, is the ability of the artery to dilate, or the distensibility. After a successful AV fistula creation, it is not the vein that always mature, the artery also mature. Unless and until the artery matures, enough blood will not go into the vein. Artery should also mature parallel to the vein. So the artery should dilate and it should bring in more blood to the vein, so that you get a good flow in the AV fistula. So before the AV fistula creation itself, we can know whether the artery has got the ability to dilate. So what we do is, we ask the patient to clench a fist like this for 2 minutes, and we'll just do a radial artery Doppler. We get a triphasic pattern. Triphasic pattern is because of the increased resistance, distal resistance. And we ask the patient to release the fist. Lot of ischemic mediators will be released after releasing the fist, and it results in the generalized arteriolar dilation in the hand, and the end diastolic velocity increases, and we'll get a monophasic flow, just like how we get in the kidney. And we can just measure the RI. If the RI is more than 0.7 after releasing the fist, that means the artery is not enough is not dilating in the proper way. The RI should be less than 0.7. That means the radial artery and its branches has got the ability to dilate, and you get a good arterial system for a good AV fistula. So we have to educate our radiologists, so we have to do it ourselves. And so this is how I just close the fist, do the Doppler, and this is how the initial Doppler is. And once I ask the patient to release the fist, the flow becomes monophasic like this. Then we have to measure the RI. RI should be less than 0.7 for a good thing. And the venous thing, we have to tie a tunica and we have to trace the vein. And tracing the vein, you can do it clinically. Clinically is much better than POCUS, I always feel, because veins are better felt than seen in the Doppler. And anything thrombophlebitis and thrombus, we can feel it in our fingertip. But in the probe also, we can see non-collapsing vein in the probe means it is thrombosed. And once the fistula is created, this is the last part, I will wind up in 2 to 3 minutes. And once the fistula is created, we have to keep the fistula under surveillance. The surveillance means clinical, plus you can use a POCUS. So the blood flow through a good AV fistula creation after the first day will be 250 to 500 ml per minute on post-op day 1, and 500 to 1000 ml per minute in 1 month after construction. So we have to what we have to do is, while monitoring or doing the surveillance, we have to study the arterial inflow side of the fistula, anastomotic chamber, and outflow of the fistula. These three areas should be screened if you are using a POCUS. So for the arterial inflow, what we do is we measure the flow volume in the brachial artery. Even if it is a radiocephalic AV fistula or a brachiocephalic AV fistula, we are measuring the flow in the brachial artery, because 90 to 95% of the flow in the brachial artery will be going to the fistula. So it is very easy to measure the flow in the brachial artery than in the fistula. If the brachial artery flow is more than 600, that means enough blood is coming to the fistula. That is very good. So we don't have to go and measure the flow at various part of the fistula. Then you have to just screen the anastomotic chamber, and you have to study the venous flow. So for the surveillance, some centers use the ultrasound for surveillance. For the surveillance, very frequently, monthly or whenever there is a need, we'll just check the flow in the brachial artery for surveillance of the fistula. They are not touching the fistula; it is in the radial artery. It is in the brachial artery only. So this is how we can see the anastomotic chamber. This anastomotic chamber with a clot inside, you can see it very clearly. This arterial needle cannulation side, we can see a partial clot, a full clot obstructing the venous side, clot. So this is how we can just look. This is a stenotic lesion. So, and once, so the first step for screening the fistula is the checking the flow in the in the brachial artery. And if the brachial artery flow is very good, then but the fistula is not performing well, next thing what we have to do is we have to find the usual arterial cannulation site. So we have to check the flow in the usual arterial cannulation site. For this, we keep the vascular probe like this. So beam is coming like this. The beam should not be hitting the flow in a perpendicular way. We have to do an angle steering. Then only we will pick up in the Doppler. An angle steering, we have to then do an angle correction. So this is the arterial cannulation site. We are going to measure the diameter at the arterial cannulation site. Then diameter can be measured the longitudinally or in transversely. I always feel this is the perfect way to measure the diameter, because we get the actual diameter here. Because of the cylinder tangential effect, we can be underestimating the diameter. And then we have to place the color flow at that area. After placing the color flow, we have to do the angle steering. So angle steering, once we do the angle steering, this is the angle steering. There will be the beam will be coming slightly in an angle, and then we have to do an angle correction and pulse wave Doppler. And angle correction is done and pulse wave Doppler, we get the flow traced like this. And the flow is not always constant. So what we have to do, in the auto calculation, we have to do the timed average mean, because the mean will change. The timed average mean is the flow velocity. We don't want the peak systolic or end diastolic. We want a time average mean. And if the time average mean is not there, we can take systolic velocity plus 2 into diastolic velocity divided by 3, which is almost give us a timed average mean. And this timed average mean into area into 60 gives the flow. Most of the time I see the radiologists don't give the flow at all, because they only just give the velocity. There is no use in absolute velocity. The velocity will increase whenever if you're measuring it in a stenotic area. If the diameter is high, velocity will come down. There is no role. We always want the flow. The flow is timed average mean into area. Area means already we measured the diameter. Half of the diameter is a radius. Pi r squared is the area. Timed average mean into area into 60 means is the flow. If the flow more than 600, it is very good. Anything less than 600 is very bad. More than 1500 is high flow fistula. So flow per minute is equals to area into timed average mean velocity into 60. And here we got the flow as 785. That means the flow is very good. So if the flow is not good in the arterial cannulation side, then there's two possibilities. Either the inflow is very bad, or there could be branches that is stealing the blood before the arterial cannulation site, which you have to palpate and see and occlude that branch and again see whether the flow is increasing. So this is how we usually screen or keep the fistula under surveillance. So the 30 minutes allotted to me is over. So I'm winding up. Thank you. I'm very sorry to rapidly rush to this big area, because it's a very big area which is very difficult to finish in 30 minutes time. Thank you.
Thank you so much, Dr. Arun. That was an excellent talk and very, very enlightening. I would like to mention that the carotid artery Doppler, I found it more superior to the concept of stroke volume variation. In stroke volume variation, we have the same concept of inspiration and expiration, but that is valid only for people who are intubated, those
Yes.
who are ventilated. But this applies to a spontaneously breathing individual, which is a non-invasive way of dealing with the respiratory dynamics. So you are combining hemodynamics and aerodynamics in such a nice way that I really appreciate. So with that, I think we can move on to the panel discussion. I will ask a few questions, and I will take up few questions from the YouTube also. To begin with, my first question is to Dr. Vivek Kumar. Dr. Vivek Kumar is a head of the critical care medicine. So obviously, as a critical care specialist, how do you assess fluid status in a patient who is post abdominal surgery status? So in post-abdominal surgery status, there will be a lot of variations in the IVC parameters and the vexus. So this is the first question to you, sir. And the next question is, we always debate that what the case Dr. Arun has said, that we talked about the total body water assessment versus the intravascular fluid assessment. So what do you think, which is a superior guide to decide on bedside how much fluid to be given or how much fluid to be removed? So, Dr. Vivek Kumar, we would like to
Yeah,
hear it from you.
yeah. Good evening, anyone. Girish, if with your permission, and I would also like to give some tips on what he has spoken and integrate it with my answer. Like
Yes.
I'll roll it out all out in one go.
Okay.
So, the first thing, Arun, I completely agree. This is clinician-directed ultrasound. Okay, so whether it is a nephrologist or a critical care specialist, it's a bedside, it's the clinician who decides. Now, the second thing, and this is with complete due respect, Arun, you remind me of my beginning years, because in one sweet way, I'm just telling you, all the images were technically limited. Your beam image acquisition was clear, but Dopplers were just not placed the correct way. There is a way you place the Doppler, you align it with the flow, and then there is a specific location where you place the Doppler. I've gone through this phase. It took me many years to learn, and I offer my services to Girish. We can hold a Nephrofocus workshop, and in any part of India, I can come down and I can teach you, and we can have some online sessions also. So the third thing is that if once nephrologists are doing their own ultrasounds, I think the first thing to take it ahead is we define competencies. That means the number of images of IVC, maybe some right heart, vexus, and of course, I am no comments on your fistulas because I don't deal with that. And then we have a small performer which I am drafting and I'll share with Girish, where exactly when you look at a person, especially as a nephrologist, or when I do a scan for a nephrologist, so I look at first is the stroke volume, what goes out of the heart. Second is the left atrial pressures, and then if there is any lung water, that is the B lines. Then is the right atrial pressures extrapolated from the IVC, and then subsequently I look at the organ venous congestion by doing a Vexus score. So it all gets integrated into one. So there it should all be a template based. And Girish, again, I don't mind. Give me a couple of weeks. I'll share this template with you. And the last
Absolutely.
thing I want to
Absolutely.
highlight is that Vexus loses its predictive value in both CKDs and CLDs. The moment an organ fails or pathologically goes into fibrosis, the pulsatility of the veins, it anyway comes down. So, however, keeping all this in mind, when I do a scan, and especially for a nephrologist, and that answers my first question and your first question here, is in any setting, you know, if I feel clinically that the patient needs fluids, so then what I do on a sonography is I assess what is known as fluid responsiveness. Whether this patient is fluid responsive, that means when I give him fluid, will his stroke volume increase? That is the correct interpretation. But if you are not measuring stroke volume by echo, then will his mean arterial pressure increase, which is a surrogate, but a very wrong surrogate. So if I have to give fluids and the stroke volume has to increase, the simplest technique, which if feasible in both spontaneously breathing and ventilated patients, is a passive leg raising, whereby you raise the leg and in the echo, you see the change in stroke volume. If you are not having an echo and you are having an arterial line, then you look at the change in the pulse pressure variation, what he has shown you. But if you are having an echo, then you can look at the what comes out of the LVOT, which is known as the LVOT velocity time integral, and that is the exact surrogate for the stroke volume. So stroke volume variation comes down, pulse pressure variation comes down if you raise the legs. This is one technique which works across whether spontaneously breathing or not breathing. Then there are other techniques also, but I think that is beyond nephrology and we leave it here. Now, one of the most important things to remember is whether it's a stroke volume variation or a pulse pressure variation, it doesn't work when the right heart is failed. You have many CKDs who have right heart failures and who have CKDs who develop right heart failures in the intensive care unit. So these markers, which are known as dynamic markers of fluid responsiveness, they are always false positive. So if you look at a patient who has a right heart failure, he will always have a false positive increased stroke volume variation or pulse pressure variation without actually being fluid responsive. So you have to draw a line here. And the most current thinking is, previously it was okay, fluid responsive, give fluids. Today, there is a second step which comes, especially in nephro patients. Is the patient fluid tolerant? So there is a definition. That means, is he congested? So if the patient is fluid responsive and fluid tolerant, we give fluids. But if the patient is fluid responsive but not fluid tolerant, that means he is already congested, giving fluids will do more harm than good. It is a measured decision. And of course, if the patient is neither fluid responsive nor fluid tolerant, never give fluid. So this is the other thing I wanted to bring around. And here I am telling you, in the setting of a abdominal surgery, by tradition, IVC loses its predictive value. And IVC is one component of VEXUS, and I will cover this in the same setting. So coming to IVC, now the first thing you have to remember about IVC, in my field, I can see small and collapsing, which is hypovolemic. In your field, you will see large, engorged, and non-collapsing, which is congested. But the moment you see a congested IVC, think of certain false positives. And one of them, the first I will say in your field, is a large pericardial effusion or a cardiac tamponade. Then you can have other causes of false positive, like a patient got intubated and he's getting a very high tidal volume. Patient gets intubated, he's getting a very high PEEP. Patient got intubated, developed a tension pneumothorax. So for some reason, the intrathoracic pressure has increased, that the IVC has become engorged. Actually, although the patient may still be hypovolemic. So that's the first thing. The second, why I am really want to say, is IVC is a 3D structure and we are seeing it in 2D. So as the current guidelines say, you measure it in a way 0.5 to 3 centimeters from opening into RA, in a way that the M mode cuts perpendicularly. This really has to be followed like a Bible, absolutely to the core. Otherwise, you will be taking different slices at different cuts at different angles, and you will actually mix up things. Now, as far as intensive care unit is concerned, even critical care nephrology, IVC is a very good marker of chronic venous congestion, but it is not a good marker of fluid responsiveness unless it is really small, less than 1 centimeter and collapsing. Then you give fluids, and if it's more than 2 and non-collapsing, then you don't give fluids. And the last thing I want to say is, currently where do I look at POCUS in nephrology? And the correct thing is, today if a patient is given to me with a AKI or a AKI on CKD for whatever reason, then I have to look at two things. Is this organ failure due to hypotension or due to hypotension and ischemia, or is this organ failure due to organ congestion? Now, previously, we all used to think that the patient has got a low MAP, so he's developed the AKI. But what studies have found is more important than low MAP is actually a organ congestion. And in the original study, it's a small fall in MAP is better than a similar increment in your venous congestion. So quickly, I have a look. Patient has developed the AKI. Is it a hypotension related issue? Yes, no, or no. MAP has always been in order, but there is organ congestion. So what I do a scan. I quickly look at the right heart function, and then I do a VEXA scan. I look at the IVC, I look at the portal, hepatic portal, and the renal veins, and I also look at the renal resistive index. So in my working algorithm, it is very clear. As a organ gets congested, it can be either because of right heart failure, or because of fluid overload, or because of a direct injury cytotoxicity to the organ, resulting in a organ congestion because of
Yes.
inflammatory edema. So
Yes.
in this case, when I look at the renal resistive index and the renal venous waveform, what I will find is that as the organ congestion is increasing, the renal resistive index will increase, because as the intra-organs pressure increase, the diastolic flow falls. So therefore, your resistive index, which is peak systolic minus diastolic divided by peak systolic, is going to go up. The second thing is, as congestion increases further, the venous flow will be cut off and the continuous venous flow becomes interrupted. It is first interrupted in diastolic phase, then it is interrupted in the systolic phase. So my question then is, why is the organ getting congested? Is the organ directly injured, or is it a fluid overload, or is it a right heart failure? And that's the way I look at it. And
So
my
in your,
second question is also answered in the same thing.
yeah,
It is only the intravascular volume which matters. The extravascular volume overload does not make a difference to the intravascular fluid status. Of course, we have to be very clear, when there is extravascular volume overload, which fluid. If I use the crystalloids, I know they're going to leak out. If I use balance fluids, I know they're going to leak out. If I use albumin, I know the leakage will be less, and then that we have to balance it out. So this is all from my. And the last thing, Girish, carotid Doppler. Stroke volume variation is best seen by echo of the heart. If you are not able to image the echo, and I do agree with nephrologists, carotid Doppler is a good surrogate, but it works equally well whether the patient is ventilated or spontaneously breathing.
yes,
And as far
absolutely.
as we are imaging the microcirculation, the splanchnic circulation is one of the earliest predictors. Along with kidney, we also see the splenic vessels. So
Thank
that's
you.
all
Thank
from
you,
my
Dr.
side.
Vivek. Thank you, Dr. Vivek. That was very nice analysis. Can we go to the next slide, Seemaji? So, Vinit, I get back to you. And see, we have done a lot of covered a lot of thing in the discussion. So the again we come to the same thing, that whether how to assess a patient if it is fluid responsive or not. Dr. Vivek has elaborated on it, and I would like your opinions on how do you assess a patient fluid responsiveness. And second thing, Dr. Arun has shown very beautiful pictures of the AV fistula assessment. AV fistula assessment was before the creation of fistula. Now I come to a question: do you do a routine surveillance of functioning AV fistula despite of clinical evidence of flow disturbances? So it is a protocol driven for you, or it is a need based for you? So the something is working very well and you are preempting a disturbance in the future. How do you go about it? Okay.
Thank you, Dr. Girish. And firstly, excellent presentation, Dr. Arun, as usual. And great to see Dr. Vivek, sir.
Yeah, we need.
I'm totally humbled and honored to be sharing the panel with you, sir. And I would be very glad to state that as early as 2013, around 12 years back, when no one spoke of POCUS or there was nothing called POCUS, no IVC or anything, we used to do the age-old measuring the CVP. That time, Vivek Kumar sir was my teacher. And he took us to the ICU and told us, this is something called as IVC. You see and assess fluid assessment. And he told us that time that in the coming years, this thing will be the standard of care. and today we have sir speaking. So it's a treat to hear you, sir. And I think there has been enough discussion on the aspect of fluid responsiveness and the various ultrasound guided measurements. So the main thrust I would emphasize is that we have to become, I mean, familiar with that. We have to adopt it. So all these new techniques like IVC, say Vexus, and all these carotid artery variations, we have to start using them. So those fine variations are there, but trust me, 70-80% of the times, even if you just have a look at the IVC, it will give you a fairly clue. So the message to you is that start using that, and it should become a strong part of your practice. And I would more speak on this on the first question, that is using the AV fistula. So I totally agree with Dr. Arun, and especially for an intervention nephrologist like me, who creates AV fistulas, does AV fistula interventions by ultrasound as well as by performing, say, angioplasty under C-arm. Ultrasound is a fantastic tool, and I would say that not using ultrasound, so creation of AV fistula as well as doing I mean, handling the complications becomes very difficult. And just to deviate from this, while creating AV fistulas, we have lost several fistulas because you just palpate the radial artery, the vein looks fairly good, you open it up, and then you find there's a thrombus. Or you
Yes,
find the artery is very small and the fistula is not viable. So you could have actually avoided that surgery by just doing ultrasound. So there is no doubt that a pre-op ultrasound should be done. Now coming to the part which we all generally don't do, that is the monitoring of the AV fistula.
yes,
After AV fistula is created, several things happens, and that, as Dr. Arun said, so the artery also undergoes some changes. In fact, as a part of AV fistula maturation, 30 to 40% is the maturation of the artery itself. So the artery also has to dilate, enlarge. So this is a very critical period, and I feel that at least first 15 days don't do anything. After the stitches are cut or after 15 days, start doing fortnightly at least surveillance of the AV fistula during its maturation stage. So you would find sometimes that there is a small juxtastenosis, or there is a small thrombus sitting around, say at the juxtac segment. So that has to be addressed. So unless you do that, this this created AV fistula goes into failure, or you don't have the proper maturation. So it is very important. So this is a practice changing behavior, because most of us generally don't do maturation follow up scans. So this has to be done. And best is that even if you can't measure the exact velocity, just a visual impression, you can catch 60 to 70%. But ideally, I feel all of us should be trained, and you should measure the proper velocity and the proper flow and the morphology part of it. Now coming to the post AV fistula while using it, the surveillance part of it. So the clinical part of it, that is the clinical examination of the AV fistula, all of us should be training our paramedics, our technicians. So they should be doing. So whenever they sense any anomaly, so that is 100%, they will send the patient to us. You do a AV fistula, and then you pick up stenosis early, or you pick up changes in flow, or you pick up early problems and address them. But as an interventionist, when you start doing AVF surveillance, and you realize that many stenosis you can actually pick up far earlier than when it has become very significant or a critical stenosis, or when the time comes that significant flow variation. I mean, there are the venous pressures or the arterial pressures, they go up. So that is generally a late stage. So if you start doing AVF surveillance, you can pick those changes quite early in the phase of stenosis being developed. Second thing is that some at the insertion points where you have the needling sites, the stenosis or the thrombus starts forming. So if you can pick it up early, it can be easily managed. Or if it hasn't become a very tight stenosis, a simple angioplasty or a ballooning with a 5 or a 4 balloon or a 6 balloon would help. So I mean, what I mean to say is that it can be addressed quite easily. It is easier to correct, and the outcomes are better if you if you pick it up early and if you address it early. Whereas if you leave it like that and you wait for it to develop a proper stenosis till it is picked up clinically, so that time you have to use multiple balloons, say high pressure balloons of 40 atmosphere, so it becomes a very difficult job. So there is no doubt that early AVF surveillance using ultrasound will definitely be useful for picking up early lesions, and this may vary as per center. The center's protocol may vary. So I generally in a period of 2 months at least, all my patients go through a ultrasound in which I check at least their anastomotic site, and the clinical examination I check the anastomotic site and the insertion points if everything is normal. So this is what I check, and in case I find anything anomaly or any early thrombus or any difference in flow or any anomaly, then I take him for a diagnostic venography. So this is what I have to say.
Yes,
That
exactly.
there's no doubt that it should be done.
So yes, Dr. Vinit, so the surveillance Doppler that you are doing, does it guide your therapy, or it is just a surveillance? Like, do you preempt the obstruction and you go about this, the correction with a stent or a balloon or something like that?
See,
Does your
the
decisions depend on the surveillance?
the flow part of it may not be accurate. Say I
Yes.
cannot do a longitudinal surveillance that my flow was initially say 600, then it either went up or went down to become 500, 450. So that can't be done. But if you are finding some early stenosis in which you are seeing a stenosis, some flow variation, which the technician may not have picked up in his examination. So
Absolutely.
those parts, if not that time, you can check up after a month and take him up for an early plasty. So
Absolutely.
that way the pickup becomes easier, and sometimes it's a evolving stage. So the thrombus is generally smaller, but he's still able to cannulate and handle. But which time with frequent dialysis that thrombus becomes enlarged, it organizes, and then it causes a full thrombosis. So those lesions, if you pick up early, it is easy to address.
Absolutely.
So
Absolutely. So I think
definitely, the outcomes are
it is.
better and the complications are lesser if we pick them up early.
Absolutely. The message is loud and clear here that we need to preempt on the fistula health, because fistula, we all know, is a lifeline for most of the CKD patients. Can we go to the next slide, please? So I come back to Dr. Arun. So see, we have talked about POCUS. We have talked about fluid management. So do you think POCUS will be a standalone biomarker? So everything based on just the ultrasound findings when we decide on fluid management in ICUs? This is the first question. And second question is, see, post-transplant, the fluid management is vital. Sometimes the patients may have urine output of say 500 ml per hour. We have seen that in our routine practice. So how do you place focus in immediate post-transplant scenario, the first 7 days, which is mostly the crucial time for all nephrologists? So we need to hear from you.
So, uh, firstly, about the POCUS, whether it is a standalone, it should never be this standalone, because I have seen a lot of patients with severe fluid overload clinically. I know that patient is in NIV, but still the resident doctors in emergency medicine and critical care just to check the IVC, they will tell IVC is collapsing. So all areas, all focus, whether IVC or vexus or carotid artery Doppler, everything do have its own limitations. So if you take one as a gold standard and act, you land up in soup. So it is an integration of everything. So clinical sense and do a POCUS, and if the POCUS is not correlating with the clinical scenario, it is not just one POCUS. If the IVC is not correlating, just check the carotid artery Doppler. So, and if it is if the patient is in hypotension, you can just check you can see the lactate, capillary refill time. So everything should be considered globally to decide on the fluid status, fluid assessment and the management, not a single value, because you can land up in soup. And the second question is how to use POCUS in early post-kidney transplantation scenario. In early post-transplant scenario, the most important POCUS which we should use is always the transplant kidney Doppler with RI. So we know that the graft kidney, it is very vulnerable to insult, acute kidney injury or a graft dysfunction because of the rejections. So whenever anything happens, whether it's acute tubular necrosis or if it is a rejection, the renal parenchymal changes happens immediately. But the reflection in the serum creatinine, it will take 12 to 24 hours or even more. So if we just rely on it, every morning and evening creatinine to follow up the patient in the initial days, you will miss up picking up a early dysfunction. So, but RI, there will be a change in the RI very immediately. So if the RI is increasing, like morning it was zero point 0.5, now it is 0.7, it is 0.8, the creatinine maybe even decreasing or it is static, we know that something is happening to the graft. Act immediately. Then we have to use our clinical sense to know whether it is an acute kidney injury because of the intravascular volume depletion or whether it is in rejection. That is all up to our clinical sense. But morning and evening RI, if you have a portable ultrasound in the transplant ICU, it is always very, very great. And regarding the fluid status assessment, we know the patient requires a lot of fluids. So every hour, keeping on checking POCUS, and also every 30 minutes we have to adjust the fluid rate. It is very cumbersome. So in the initial post-transplant days, I always feel that already there is a central line, so we can have a line connected to the CVP monitor, and we can just check the CVP, and arterial line will be there. So PPV variable, the pulse pressure variability can be seen in the monitor, and the urine output, etc., can help us from doing a frequent POCUS, because otherwise every 30 minutes and 1 hour we have to keep on doing the POCUS, which I am not a fan of that. But morning and evening I always like doing, because to pick up any renal dysfunction at the earliest. And whenever there is a doubt in the CVP or anything, sometimes I use a POCUS to check the carotid artery peak systolic velocity variation, and the IVC and all. I don't want to tamper the patient's tummy and all very often with the probe. So that's my take on it.
That's fantastic. I think there are so many take homes today. So, Dr. Manan, are you around? Do you have any questions?
Yeah, hi.
Please go ahead.
Yeah, so my question would be, has anybody actually tried using or comparing bioimpedance versus POCUS in patients with CKD on maintenance dialysis to see the fluid overload state? And if anybody has clinical experience with that?
Shall I tell? So there are
Yes,
a
yes,
lot.
because I saw your paper published on that. So I think you can answer this.
So bioimpedance and clinically assessed dry weight versus bioimpedance, there's a lot of studies. Clinically assessed dry weight versus the POCUS, there are a lot of studies. So direct head-to-head comparison with the POCUS and the bioimpedance, very limited data. But one thing is very clear. So clinical assessment of the dry weight is always far inferior than bioimpedance, and also with the POCUS. So because most of the time patient will be running at a very high weight. So if we just apply bioimpedance or the POCUS, we can significantly reduce the weight in at least half of the patients, and you can give a better outcome. So that is very clear. But head-to-head comparison, we have to wait.
Okay, so I think that's it for today. If there are any other questions, Manan?
No, I think we have covered most of it.
So it has been 1 hour, fantastic discussions. So what I see is there are many gray areas, but our knowledge has almost doubled since the last 10 years of we are using POCUS. And I think we should keep doing it more often and come up with some guidelines, because as Dr. Vinit mentioned, the guidelines, they are changing from center to center. There may not be uniformity, and the uniformity is not there because there is no uniform training in POCUS. So with that, I think we should train more, we should learn more, and look forward to POCUS being a very useful tool for our clinical practice. With that, I must thank Dr. Arun, Dr. Vivek Kumar, Dr. Vinit, Manan, Seema, and Saurabh for making this a wonderful session. This will be available on YouTube. So if any of your students want to hear it or listen to it, they can do it anytime. So everybody, a good night from Nephrocon, and please take care. Thank you.
Thank you, everyone, and good night.
Thank you. Good night.
Good night.
Thank you. Good night. Thank you.